Okay, testing. Hi, my name is David Sun. I'm a family doctor here in Edmonton, Alberta. I'm just a very standard family doctor. I have my solo practice. I'm not really involved in teaching. I'm not really involved in any sort of research. Very laid back usually. And I'm not usually the type of person who likes to get into the nitty-gritty specific numbers, etc. I just want to know sort of the practical aspects of how to practice and how to help people. So this is something that I haven't done before. I just want to discuss with all my colleagues out there in Edmonton, Alberta, Canada, maybe elsewhere, where you might be a family doctor, our role in the current coronavirus pandemic. So of course we want to do our basic roles in providing advice and support. And for example, I'm trying to send my patients updates because we do have an email listing through our EMR, so I keep them updated on certain topics. And of course, we should maintain the optimal health of our panels. And we should probably be involved in testing because here in Edmonton, Alberta, and rest of Canada, we use hotlines, and those hotlines are being overrun. And many people aren't getting their proper testing. And so I've done testing for some of my patients, but I know that elsewhere in Canada, I spoke with a friend in Montreal, they don't have the proper PPE, they can't do testing in their clinic, so they have to turn people away. And I think that's a big problem. Sometimes I've taken initiative to test some of my patients who have traveled, have symptoms, and I try to reduce the risk by testing them in their car. It could be something that other people can consider. So in terms of dealing with this pandemic that's got a relatively high mortality rate, we're still not sure of the number. Is it 1 to 2% that's generally floated around, or is it really less than 1%, or is it even higher than 3%? I guess the exact number is relevant. We know that there's very high rates of hospitalization, 19%, including 5% critical if you look at the data from China. Of course, it has to consider the baseline health of the population, but certainly if we could do something about lowering the risk for those high-risk individuals, such as those people with underlying health issues and seniors 65 or over, then maybe we want to do something proactive, okay, to reduce likelihood that they'll enter the hospital and overwhelm our hospital system. So I don't think there are any local clinical guidelines anywhere in North America in terms of treatment. We're just talking about supportive care, but it might be considered that we should look at guidelines elsewhere, perhaps not yet evidence-based, but if there's a good rationale, and if we look at the risk and benefit, that it heavily weighs towards benefit, that it might be something to consider. Let me just check I'm not disconnected. Okay, I'm still going. Okay, good. So I just want to share with you, because there's a lot of talk about the use of zinc for treating colds and influenza, etc. Of course, there's not enough data, and no one fully supports this idea. But definitely, if you look online, there's lots of people trying to stock up on zinc lozenges. And so there's not enough information to support its use. And the reason that people are interested in zinc is that we know that zinc inhibits viral replication. So if you look at these in vitro studies, when you pump zinc into the cells using an ionophore, so channeling the zinc inside the cell to create high concentrations, it reduces the replication of the RNA virus by interfering with the viral polyprotein processing. Okay, so this can't be directly extrapolated to human use because we don't have a naturally existing ionophore. We're not just going to consume zinc through a diet or as a supplement and then just make our intracellular levels of zinc very high. But are there methods for increasing the zinc in our cells? And the answer is yes. So we do have many articles from years ago that have demonstrated that there are medications such as chloroquine, which is an old medication for treating malaria, that it's a zinc ionophore. And if you look at their in vitro studies, if you provide the cells with zinc together with chloroquine, there's significantly increased absorption. In fact, if you look at here where you have 50 micromoles of zinc versus 5 micromoles of zinc, but with chloroquine added together, there's actually even more zinc than here, right? So it is clear that chloroquine increases cellular absorption. So the Chinese and the Koreans have been using chloroquine and also hydroxychloroquine in the treatment of SARS-CoV-2, and there are in vitro studies that clearly show that even specifically for SARS-CoV-2, both chloroquine and hydroxychloroquine are able to inhibit the viral replication. And in fact, hydroxychloroquine, which is a safer alternative to chloroquine, is even more potent than chloroquine to inhibit SARS-CoV-2 in vitro. And that is great because hydroxychloroquine is even more familiar to family doctors because we use it, the commercial name is Plaquenil. We use it for a lot of patients for autoimmune diseases and, including rheumatoid arthritis, etc. So it's a common medication that we use for our senior populations. Okay, so we're familiar with the side effect profile, and it is rather cheap, and it's readily accessible. So if you look at the Johns Hopkins website, they're mentioning that there are many drugs under investigation. Compared to all the other medications that are under investigation, chloroquine, hydroxychloroquine, it's definitely way cheaper and much better understood in terms of safety profiles. The other medications are probably very expensive, and we don't know, about the long-term, the consequences and side effect profiles. So it is something to consider. So for family doctors, if we're considering that the fatality rate for our seniors is so incredibly high, and the hospitalization rate is probably way higher than that, okay, we have to, just ask ourselves, what is the risk of using hydroxychloroquine, which is Plaquenil? And here in their study, they recommended that you could use a 400 milligram twice daily loading dose followed by a 200 milligram maintenance dose for 4 days. So that's a total of 5-day treatment. What is the harm, okay, for using 5 days of Plaquenil if we could reduce hospitalization? Okay, reducing hospitalization means much less burden for our healthcare system, much less chance of cross-contamination and nosocomial infections. I think it is well worth taking the risk. Hydroxychloroquine has some risks and probably is contraindicated in a few people, but it's probably for the vast majority of people worth it despite those risks, because if you think about the hospitalization rates. And the same thing goes along with zinc. Zinc probably has some side effects, and we certainly probably would not recommend using zinc to use as a preventative medication because zinc can cause reductions in copper absorption, can cause anemia and other issues, but maybe just 5 days of zinc together with zinc ionophore, that's probably safe, I would imagine. So that's for something to think about. And then I guess the question is, are there even other zinc ionophores then to just use? So, and there are, if you research, there's probably many zinc ionophores, and including some are just dietary supplements. And we don't know, again, how well these things would work, but again, what's the harm of giving a dietary supplement such as a flavonoid? Okay, so here, quercetin is probably very commonly quoted, and in fact is the focus of research for our Canadian Montreal researchers, and here they have actually sent quercetin to China to see the effect of the medication, and this is supported by the Montreal Clinical Research Institute. They're pleased to announce that they are sending quercetin to combat SARS-CoV-2, and quercetin is also researched in vitro. They've shown that it is strong in the inhibition of viral replication. So it has been published that quercetin can probably also inhibit SARS-CoV replication, because this research was started after the SARS outbreak. And there is more and more in vitro evidence that quercetin and other supplements can do the same. Flavonoids. This is what is found in green tea. And again, we don't have any evidence that green tea would be helpful. But again, what is the harm of providing quercetin or green tea supplements? And something else for family doctors to be aware of is that this is very, very new news, that anti-inflammatory drugs such as Advil might make infections worse. And they said that maybe it's because of the anti-inflammatory effect, and we shouldn't reduce inflammation. There's no research papers out yet, but this is coming from their French health minister. But just a few days prior to this news, there was a paper in The Lancet that looked at the concerns with the increase in expression of ACE2 inhibitors, and that possibly can increase viral infection because the SARS-CoV-2 virus binds to the ACE2 enzyme on the cells, and if we increase the expression, that can facilitate the virus getting into the cells and possibly replicating much faster than normal. And maybe that is the effect. If our immune system is delayed in responding and the viruses are replicating way too fast, then people get into cytokine storm way too quickly. So here they mention also that ibuprofen probably increases ACE2, but what is probably more concerning for family doctors right now would be the use of ACE inhibitors and angiotensin II receptor blockers. Is that something that we should be worried about? And we're going to need to wait for additional data. Certainly, I've tried to tell people who are aware of this news to not stop their medications early without talking to their doctors. That can be harmful. But for the patients who might not have, cardiac or renal concerns treated for hypertension, maybe family doctors can consider using a calcium channel blocker. So again, this is very early news, and I'm not sure how we're going to use it, but we need to be aware of it, and we might, again, proactively do some things to reduce the chance of a hospitalization. So again, what I treat off-label with hydroxychloroquine, I certainly would be comfortable in doing so. Maybe for other people, we can just even consider giving them a supplement, such as the quercetin. Can quercetin be used as a preventative measure? I don't know. And should we change, again, the use of ACE inhibitors and ARBs, and maybe avoiding the use of ibuprofen? It's all things that we need to be considering and getting that message out to our patients if it seems to be the fact. So again, I think family doctors, we should be more proactive. I'm trying to, again, keep my patients updated through electronic communication with the EMR. And again, it's all about the risk and benefit. We cannot let the epidemic curve go above our healthcare capacity. So thank you. Please tell me what you think about all this information, and I hope you can share it if you think it would be helpful.